Good evening, everyone. Welcome to our 87th Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leaders in creating a skilled community through easily accessible knowledge in preventive medicine. I'm your host, Adam Getachew. I'm the co-founder and CTO at Blue Health Ethiopia, and we are honored to have Dr. Yonatan Getaneh here with us to give us a brief discussion on the topic of management of asthma in the emergency department. To give you a little background on Dr. Yonatan is an assistant professor of emergency medicine and critical care specialty, and he has been working with us under he has also given previously a virtual seminar, and also he have been working with us together giving workshops on different emergency topics and trainings and things like that. So we would like to thank him for giving this session for us.
Thank you, Adam, for the warm introductions. Hello, everyone. I hope you guys had a pleasant day. Today, we're going to have a short discussion on management of asthma in the emergency department. Okay, so let's, I think, proceed to the introduction. So I think we're all familiar that asthma is one of the leading causes of morbidity as well as mortality throughout the world. It is usually defined as a heterogeneous disease, usually characterized by chronic airway inflammation, and has characteristic symptomatic features of wheezing, shortness of breath, chest tightness, and cough, which may vary over time and as well as in their intensity, and they're also characterized by variable expiratory airflow limitation. Although most acute asthma episodes improve spontaneously or usually within hours with treatment, patients might present with a more pronounced and more severe presentation, which could be life-threatening, and we will try to address how we will manage in the emergency department today. We know asthma affects around 8% US population, and in one study, in one systemic review and meta-analysis done in Ethiopia, its incidence in pediatric patients was up to 8.7%, and it's one of the most common chronic diseases of childhood with a 9% prevalence in our setup. Half of the asthma cases will typically develop by 10 years of age, and another third will usually develop by the age of 40. So we know that asthma is a condition which is characterized by abnormal accumulation of eosinophils, lymphocytes, other inflammatory cells like macrophages, mast cells in the airways. And the hallmark of asthma is that it results in reduction in the airway diameter caused by smooth muscle contractions as well as vascular congestion and bronchial wall edema. And also has thick mucus production, which might block up the airways. So these changes create a pulmonary function changes, which increase the work of breathing and abnormal distribution of pulmonary blood flow. Large and small airways might contain plugs created by mucus, serum proteins, as well as inflammatory cells due to this condition. And acute asthma is an exaggerated airway response to a variety of external exposures. Most commonly viral upper respiratory tract infections. Most stimulants which precipitate an asthma attack, which accounts for around 40 to 80% of episodes in adults, up to 80% in children. This is also continuing from acute bronchospasm through airway inflammation to which may lead to permanent airway remodeling. And certain conditions, certain medications as well can contribute to bronchospasm, which like aspirin and steroidal anti-inflammatory drugs, which also are involved in mediator release from the airway cells. So I think we're all familiar with the common precipitants for asthma. It can be precipitated by a wide range of external stimuli as well as activity like exercises. And external stimuli could be like mold, house dust mites, animal number, or any dust from wood, vegetables, medications, as I mentioned earlier, as well as industrial chemicals, plastics, biological enzymes, vapors, gases. Even change in estradiol and progesterone levels and emotional stress can also precipitate asthma. Early recognition of acute asthma and treatment before the exacerbation becomes severe are very essential for acute asthma management. Though we might rely on the history, on previous history of asthma to ascertain that the current presentation is due to that, some patients might not present with a prior history of asthma, which might make the diagnosis a bit more challenging. So the severity of acute asthma is categorized based on the clinical features, and some clinical features will be usually patients will present with cough, wheezing, chest tightness, sputum production, and fever. And there are certain patterns and disease histories associated with each of these presentations, which might give us a clue that this is caused by an acute asthma attack. So if the cough is usually perennial or seasonal, or have diseases for cigarette smoking, this can be also one indicator that it could be asthma related. The wheezing might be continual or episodic, and it might they might present with a previous history of management or medications consistent with treatment of asthma. And some shortness of breath could be characterized by the onset and the pattern of the presentation as well. So in addition to these features, there are certain risk factors that we need to assess whenever we are dealing with a suspected asthma attack. These risk factors could be, for a reason, these specific risk factors are risk factors which might result in the death of the patient from asthma, and these are usually indicated by the presence of a past history of severe exacerbations. Other factors could be if the patient has a history of repeated admissions or hospitalizations in the past year, especially if they have more than 2 hospitalizations in the year. And if they have history of repeated treatment for asthma in the emergency department, especially more than 3 episodes. And if they're consuming more than 2 canisters of a short-acting beta-2 agonist, these are some factors which might give us a clue that this patient might have a higher risk factor for death due to this exacerbation. The other could be difficulty perceiving airflow obstruction or its severity, which might occur in patients who have underlying psychiatric conditions or who are also having some sort of neurodegenerative condition as well. Having low socioeconomic status and inner city residents, like the people who live in very congested, unhygienic environments, are also at high risk for continuous exposure and having severe exacerbations. So these will be one risk factors for asthma-related death. And those patients who also have illicit drug use or other medical comorbidities might also have an increased risk of death. So the typically find the patients to be in respiratory distress, and we need to assess for their level of consciousness, their vital signs, specifically their oxygen saturations, presence of tachycardia or tachypnea, and presence of pulsus paradoxicus can also be things that we need to look for in the vital signs. Chest findings typically will find wheezing, but it's an unreliable indicator of airflow obstruction in acute asthma. Even patients who have severe airflow limitations might present with what we call silent chest, but it doesn't necessarily correlate with the degree of airflow limitation. So on their respiratory exam, we might also assess for the presence of any use of accessory muscles and whether they're able to speak in full sentences or phrases, and the presence of pulsus paradoxicus, that's a drop in their systolic blood pressure by 15 millimeters of mercury during inspiration, can help to identify those patients who are having a severe acute asthma attack. We need to also identify pneumonia, pneumothorax, or mimicking conditions such as upper airway obstruction or foreign bodies and vocal cord dysfunction. The latter of which typically it will be a reason for frequent ED return visits, and they usually get labeled as having refractory asthma if we don't identify and treat any underlying conditions that might be present as well. Important asthma mimickers could be what we refer to as cardiac asthma or acute heart failure. Those patients who are having upper airway obstruction can also present with wheezing, which might confound the diagnosis. Those patients who have pulmonary embolism might sometimes present wheezing and significant respiratory distress, and aspiration of foreign body or gastric acids. Certain tumors involving the endobronchial tree or presence of chronic lung disease, interstitial lung diseases, as well as presence of paralysis can be some mimickers for asthma. So coming to the diagnosis, examination findings and subjective symptoms do not necessarily correlate well with the severity of the airflow obstruction, but the FEV1 and the peak expiratory, that's forced expiratory volume in 1 second, and the peak expiratory flow rate are very key objective measures to assess for the severity of an acute FEV1's advantage is that, in contrast to the peak expiratory flow rate, it can help us to distinguish between poor effort as well as other restrictive lung disorders, vocal cord dysfunction, and obstructive disorders such as asthma. But the peak expiratory flow rate measurement has more clinical utility in the emergency department whenever available, because it can help to monitor the response to the treatment. So we can either repeat either the FEV1 or the peak expiratory flow rate, because comparing the measures at initial presentation and like 1 hour after treatment is one of the best predictors for deciding whether hospitalization is going to be required for this particular patient. So pulse oximetry assesses the oxygen saturation during treatment, and it should ideally be done for all patients with asthma exacerbation whenever feasible. And in children, oxygen saturation should normally be above 95%, and saturation less than 92% is a predictor of the need for hospitalization, even though it's a low-class evidence. Certain saturation levels below 90 in children and adults could also signal the need for more aggressive therapy, and it could be a subject to clinical urgency. Saturation should be assessed before oxygen is commenced, and we need to at least assess frequently reassess their oxygen needs and responses before and after initiating oxygen therapy, as well as when nebulization might be conducted. So the other point I want to raise here is for those patients with peak expiratory flow or FEV1 less than 50% of predicted, or for those who do not respond to initial treatment or are deteriorating, it's very important to consider maybe advanced the needs of improving their oxygenation, like using non-invasive ventilation or mechanical ventilation. So ABG measurements might not be needed in patients with mild to moderate asthma exacerbations. We typically reserve it for suspected hypoventilation with patients who are CO2 retainers or who are suspected of respiratory acidosis, so routine measurement of clinical importance. The most important marker that we can use could be the presence of fatigue in somnolescence, which suggests that their partial arterial CO2 level may be increasing and airway interventions might be required. So if ABG is done, the partial arterial oxygen less than 60 and normal or increased partial arterial CO2 of above 45 is indicative of respiratory failure. However, if there's a normal or slightly elevated partial arterial CO2, especially if it's above 42, we need to consider that this patient might have an extreme airway obstruction, and we need to assess them clinically whether they are fatigued. And we need to consider that these patients might be in potential acute ventilatory failure or type 2 respiratory failure. For those patients with impending respiratory failure, almost always have clinical evidence of severe acute asthma or spirometry demonstrating a peak 25% of predicted. So this is a common trend which is being initial peak expiratory. It is especially less than 25, you need to consider that this patient is in impending respiratory failure, and as much as possible needs to be in a well-monitored setting. Okay, so the other point in monitoring of these patients could be the use of capnography in acute asthma management. So the evidence behind this is a bit it's a bit contradictory in certain terms, like use of capnograph in acute asthma is still unclear. There was one small study which reported that there was good concordance between expired carbon dioxide levels measured by capnography and arterial carbon dioxide concentrations. But there was another study which reported that there was a variation of more than 10 millimeter of mercury between the two approaches. Therefore, its clinical utility is still of uncertain value. So another adjunct that we could use could be chest X-ray. However, it's routinely recommended for use in adult patients with acute asthma exacerbations. You need to always consider imaging these patients with radiograph whenever there's an alternative cardiopulmonary process which is suspected, especially in the elderly patients because of the higher risk of infectious complications. And we need to also consider chest X-ray in those patients who might not be responding to initial treatment, where and in conditions where a pneumothorax may be difficult to diagnose clinically, as that could be one of the reasons for inadequate response to treatment could be due to one of the complications of this asthma, which is pneumothorax formation. Some studies show that less than a third of the patients have an abnormal chest X-ray, and on GINA, it suggests that almost only 2% of imaging chest X-rays we have any abnormalities related to the current presentation. So the investigations on the CBC, there could be modest leukocytosis, which could be secondary to the beta-agonist therapy and or corticosteroid uses, and that could be one feature that we may see during our evaluation. And routine ECG might not be necessary. It's often normal and is non-specific to the current condition and might not reveal any pertinent findings. But whenever present, if there is a due to the airway remodeling, chronic airway remodeling, and onset of maybe pulmonary hypertension, it might reveal some right ventricular strain, abnormal P waves, or non-specific ST wave changes. And transiently, we might also, these features might also be transient. They might improve after the initial consultation. So use of cardiac monitoring in older patients and those with coexisting heart disease is recommended during the course of their treatment in the emergency department. So coming to the acute asthma standard treatment, our goal for our patients is always to achieve a rapid reversal of airflow obstruction by administering inhaled beta-2 agonists, ideally short-acting ones, and making sure that we have adequate oxygenation and decreasing the inflammation. So whenever we are, whenever we are faced with a patient in the emergency department with an acute exacerbation, our initial assessment should always follow the ABC of life. So after we assess the airway breathing circulation, we need to initially see whether this patient is at risk or is having a life-threatening exacerbation of asthma. We can do this by assessing their level of consciousness and seeing whether they're drowsy, confused, and whether they're having a silent chest. If these features are present, we need to immediately take them to a resuscitation area or consult our ICU and start short-acting beta-agonists and oxygen therapy while preparing to immediately or emergently intubate the patient. If these features, however, are not present, we can triage the patients based on their clinical status according to the severity features. So on GINA, it classifies an acute exacerbation as either mild or moderate to severe or life-threatening. So we generally consider a patient to have a mild or moderate exacerbation if they're talking phrases or sitting to lying position, are generally not agitated with increased respiratory rates, but no more than 30. And no use of accessory muscles with a heart rate of around 100 to 120. And if their oxygen saturation is around 90 to 95% on room air. And if their peak expiratory flow rate is greater than 50% of predicted or their best previous value, if that's available. We'll consider it a severe exacerbation, however, if the patient is talking in words, sitting hunched forward, agitated, with respiratory rate greater than 30, with visible use of accessory muscles, and if they are tachycardic above 120 with a saturation of less than 90. And the peak expiratory flow rate is also very useful in assessing the severity of exacerbation. Again, if it's less than 50% of predicted or rest, that could be indicative of a severe exacerbation. So I think we'll discuss the management in detail, but just to cover the moderate exacerbation management here, we'll usually use a short-acting beta-2 agonist and oral corticosteroids as soon as possible, ideally within an hour of presentation to the ED, whenever possible. We might consider apratropium bromide, and we might consider supplementing them with oxygen to maintain this air saturation between 93 to 90%. But if we're dealing with children, it should be 94 to 98, and pregnant women should be about 95. And we'll come in detail to the managements here, but ideally we don't start all the medications except the SABA and the oral corticosteroids all together. We will usually reassess them after an hour of treatment, and then based on their clinical response or based on their peak expiratory flow rates, if there's any improvement, we will decide on our management. Okay, so I briefly discussed it earlier. Our goal is always to achieve an oxygen supplemental oxygen should be given to attain an oxygen saturation around 93 to 95% in adults, and around 94 to 98% in children between 6 to 11. And we can use this, we can administer this oxygen via various delivery devices like nasal cannulas or face masks. The other part of the treatment is using short-acting inhalational beta-2 agonist. It's the most cost-effective and efficient delivery way. The delivery method is using a pressure meter dose inhaler with a spacer. The evidence is, however, less robust in its use for severe or near-fatal asthma, rather than pressurized meter dose inhaler. Nebulization might be our option for those patients who are having severe or near-fatal asthma attacks. Regarding the use of IV beta-2 agonists, there is no recommendation which supports its use whenever we are faced with these types of conditions. So the other thing here regarding meter dose inhalers, we could use various forms. We can use albuterol or levalbuterol, which are both short-acting beta agonists. However, albuterol is more widely available and less costly as compared to levalbuterol, which is around up to 25 times more expensive with no clear advantage for its use. And even with the optimum technique use of these short-acting beta agonists, a maximum of around 15% of the drug dose is going to be retained in the lungs, regardless of the aerosol method which is being used. So that's why it's more recommended currently to use a meter dose inhaler with a spacer, because a spacer device is normally attached to the inhaler and it improves the drug deposition when optimally used. So it also allows for a more coordinated respiratory effort. If the patient doesn't have good hand-mouth coordination to inhale the medication due to the respiratory distress, there will be inefficient consumption of the medication, which again, as I said, only 15% of it, even with appropriate use, is going to be delivered to the lower airways. So it's very important that we allow them adequate amount of inspiratory time, and using a spacer will allow us to have to achieve that by giving them more time to inhale the medication more completely and more appropriately. So in a severe or near-fatal asthma exacerbation, nebulization of beta agonists is recommended. The pressurized meter dose inhaler. However, there is some positive data regarding this recommendation as well. So the other class of medications which we'll use for these patients is typically corticosteroids. So regarding corticosteroids, corticosteroids are used in all forms of exacerbation except the mildest form. We typically don't need to use corticosteroids for oral corticosteroids for patients who are having mild exacerbations. The peak anti-inflammatory effect of these agents occurs typically at around 4 to 8 hours after IV or PO medication ingestion. So its early use is recommended, especially within the first hour of arrival in the emergency department, so that we can reduce the need for further hospitalization. So the other thing, restoring beta-adrenergic responsiveness and reducing inflammation are some of the advantages of using corticosteroids. And it will also help us to have less likelihood of recurrence or less likelihood of re-exacerbation in the short term. So regarding whether it should be administered intravenously or orally, oral administration is just as effective as intravenous administration, and intravenous corticosteroids can be administered whenever the patient has features like if they are too dyspneic or too much in respiratory distress to have coordinated swallow, or if the patient is having persistent vomiting, or if the patient requires non-invasive ventilation or intubation where oral administration might not be feasible, we can consider using the IV agents. Other than that, oral and IV medication use is pretty much the same in their efficacy. So regarding intramuscular corticosteroids, it has been reported as an alternative to oral corticosteroids to prevent relapses, but it has a much longer onset of action and is not typically useful for management in the emergency setting. So the doses of oral corticosteroids are equivalent to around 50 milligrams of prednisolone as a single morning dose, or 12 milligrams of hydrocortisone in divided doses are typically used for adults. However, for children, we can use weight-based dosing at 1 to 2 milligrams per kg for prednisolone, a maximum dose of around 40 milligrams per day. So 5 to 7 day course of use of these oral corticosteroids in adults has been found to be just as effective as a longer course of and evidence from studies in which all these patients were taking maintenance inhalational corticosteroids after discharge suggested that there is no benefit in tapering the oral corticosteroids either in the short term or over several weeks. So even abrupt discontinuation is fine as long as they don't take it for a period more than 5 to 7 days. So the current recommendations are also to use inhaled corticosteroid for patients with mild persistent asthma or more severe chronic asthma, i.e. whenever discharging these patients with mild persistent or more severe asthma, we need to make sure that maintenance inhalation corticosteroids are added to any systemic bursts that we're giving through the oral route. So we have various choices like beclomethasone, budesonide, mometazone, and other agents, but the one we typically have available in our country is beclomethasone, and in certain conditions, budesonide is also available. So high dose of inhalation corticosteroids given within the first hour again helps to reduce the need for hospitalization in these patients who are not going to be receiving systemic corticosteroids. And whenever we add them to systemic corticosteroids, evidence is conflicting in adults, and use of both inhalational as well as systemic corticosteroids is still controversial, and there's no current guideline which supports it. So patients which are admitted to hospital for an asthma exacerbation should continue on or be prescribed an inhalational corticosteroid containing therapy once they are stable. And on discharge home, they should be prescribed the inhalational corticosteroid containing treatment, since the occurrence of a severe exacerbation is a risk factor for future exacerbation as well. So inhalational corticosteroid containing medications significantly reduce risk of asthma-related death or hospitalization as well as recurrence. So SABA-only treatment or short-acting beta-agonist-only treatment of asthma is no longer recommended according to the GINA guidelines. Okay, sorry. I think I was speaking too fast. Okay. All right. Other agents that we could use could be anticholinergics, which could be used as a additive therapy to beta-adrenergic agents. Patients with moderate to severe exacerbations could also benefit from use of ipratropium bromide, which is available as nebulized solution as well as a metered dose inhaler or as a combination inhaler with SABA like albuterol. So use an aerosolized ipratropium bromide solution at 0.5 milligrams whenever its need is warranted. So anticholinergics affect the large airways as well as the central airways, whereas the beta-adrenergic typically dilate smaller airways. Treatment in the ED with both SABA and ipratropium, short-acting anticholinergic, was associated with fewer hospital admissions, and there is some recommendation for their use concurrently. And it has been shown that it has greater improvement in their peak expiratory flow when we compare it with the use of short-acting beta agonist alone. So for children which are hospitalized for acute asthma, there was no benefit which was observed from adding ipratropium to SABA in regards to the length of stay, the risk of nausea, or other cholinergic symptoms like tremors. So adding multiple doses of ipratropium bromide to a SABA may improve bronchodilation and decrease the rate of hospitalization among those patients with moderate to severe exacerbations, although this benefit is not universal. Okay, coming to aminophylline or theophylline. IV aminophylline and theophylline is no longer used in the management of asthma exacerbations because they have poor efficacy, they have a horrible safety profile, and there are agents with greater efficacy like short-acting beta agonists, and they have high degree of other adverse effects like nausea, vomiting, which is associated with aminophylline, and certain fatal side effects have also been observed with IV aminophylline, especially in the elderly population due to the higher incidence of tachydysrhythmias. So in those adults with severe asthma exacerbation, add-on treatment with aminophylline does not improve their outcome when we compare it with the use of SABA alone. So its use has been reduced and actually eliminated to a certain regard. So the other is the use of magnesium. So magnesium sulfate is not recommended for use for routine use in asthma exacerbations, but some randomized control trials which have shown that its use might help in those patients who are having severe life-threatening asthma. And the dose to which you need to administer it is typically around 2 grams, which needs to be administered over a period of 20 minutes intravenously. And there is some debate about whether inhalational magnesium is more effective than IV magnesium, but there have been other studies which showed that there was no significant benefit in the use of IV or nebulized magnesium over the other. So dosing regimens varied for the studies which they used. Typically, they used around 95 milligrams of nebulized magnesium sulfate in 4 divided doses, which were administered every 20 minutes for an hour. And another one was 384 milligrams of nebulized magnesium in sterile water, but even a higher dose did not show that it had a much significant effect. So again, it can reduce hospital admission in some patients. Again, it's not beneficial for all patients. We have to use it for those patients where their initial FEV1 is usually less than 25% of predicted presentation. And for those patients who typically are not responding to their initial treatment and have persistent hypoxemia, and children whose FEV1 fails to reach above 60% of predicted after 1 hour of care, we can consider using magnesium sulfate. So again, for patients who are not improving, or those patients who are having severe life-threatening exacerbation with an FEV1 less than 25%. or near fatal asthma, it's recommended to use magnesium sulfate. Okay. So coming to other oxygenation strategies that we may use in case our oxygen delivery through supplemental oxygen administration is not effective, we can consider using non-invasive ventilation. But the evidence regarding its role in asthma is again weak. It's a low level of evidence, but if NIV is tried, it should be in a patient who is going to be monitored very closely, and it should not be attempted in those patients who are having signs of hypoxia like agitation, and those patients who are extremely agitated and non-cooperative with other contraindications for non-invasive ventilation. We should not attempt it. But for the other patients, we can consider using it again. And whenever a patient is on NIV, we need it should go without saying, but we should not be sedating these patients in order for them to receive non-invasive ventilation, because that has disastrous consequences. We need to also exclude complications like pneumothorax before beginning any form of positive pressure ventilation, whether it's non-invasive or invasive. There are new methods of oxygen delivery which are being introduced, like something called heliox or helium oxygen therapy. So it's a mixture of helium and oxygen at 80% helium, 20% oxygen formulation, and it can help to lower airway resistance and aid in the treatment of severe acute asthma attacks. Although there is no role for this intervention in routine care, it can, however, be an option for those patients who don't have therapy. And there has been a systematic review which compared helium oxygen with air oxygen, suggests that there's no role for this intervention in routine care. Again, we can use it for those patients who are non-responders to the standard therapy. So the availability, cost, and technical issues should also be considered. I don't think it's feasible in our country, but it's good to know that it's out there. So other agents that we could use could be leukotriene receptor antagonists. Again, this could be like mast cell modifiers like cromolyn or nidocromil, which have an anti-inflammatory action by blocking chlorine channels and therefore modulating mast cell mediated releases and eosinophil recruitment. So these agents inhibit early and late response to allergen challenge and exercise, and they are not actually indicated in the treatment of acute bronchitis. So there's limited evidence to support their role for oral or IV administration in acute asthma. There has been small studies which demonstrated improvement in lung function, but clinical role and safety of these agents requires, I think, additional studies as well. So coming to one of the new updates from the GINA 2024 guideline, using inhalational corticosteroids with a long-acting beta agonist combination. Their role of these medications in the emergency department of hospital is still unclear. There's no evidence that budesonide formoterol would be less effective in managing asthma exacerbations, but there's no published data for its use in the emergency department. Neither for inhalational corticosteroid with short-acting beta agonists as well. So typically, if we are going to use an inhalational corticosteroid LABA combination, it should be after the patient has been stabilized, or if the patient is not going to be receiving oral corticosteroids, like a patient who is receiving treatment for a mild exacerbation, we can consider using the inhalational corticosteroid LABA combination. But however, if they are going to receive systemic corticosteroids, there is no particular role or evidence for using it in the. Okay, the other is regarding the use of routine antibiotics. There is no evidence which supports routine use of antibiotics, provided that there is no strong evidence for lung infection. So we need to look for features like the presence of fever, purulent sputum, or any other radiographic evidences for pneumonia. So again, sedatives must be avoided. If you are finding an agitated patient due to an asthma attack, it's likely due to the hypoxia or due to the respiratory distress. So you need to make sure that you treat the underlying cause, which is the hypoxia, and you need to avoid sedation at all costs. It's again very dangerous thing to perform in patients who are in this condition. The other is regarding the use of fraction of exhaled nitric oxide. So that's another method of treatment which is starting to be very popular around the West. It can help to see the degree of improvement in airway limitation as well. So that's one thing we should be aware of. So since the guidelines will start to be talking about it more and more. Okay, regarding mechanical ventilation should be reserved for those patients who are having progressive hypercarbonation, and we need to make sure that we institute mechanical ventilation early so that we can prevent respiratory arrest, so that we can prevent respiratory arrest. So the other is mechanical ventilation does not relieve the airflow obstruction, and it merely reduces the work of breathing, and it enables the patient to rest while the airflow obstruction is resolved. The potential complications which are associated with mechanical ventilation in asthma is there's typically commonly they'll develop high peak airway pressures, which might result in the development of barotrauma and hemodynamic impairment by decreasing of the preload due to dynamic hyperinflation as well. So mucus plugging also is frequent, which will lead to increased airway resistance, atelectasis, and obstructive pneumonia. So there's also high risk of auto-PEEP. Its use in the use of rapid inspiratory flow rates at a reduced respiratory frequency and allowing adequate expiratory time can help to treat the to help treat auto-PEEP once it has developed. So it's reasonable for us to keep targeting an adequate arterial oxygen saturation above 90 without concern to normalize the hypercarbic acidosis. So this approach is referred to as permissive hypoventilation or controlled hypoventilation. And ventilation of patients with acute asthma might require the use of sedatives and neuromuscular blockers, but extended use of neuromuscular blockers has risk of post-extubation muscle weakness, so it shouldn't be routinely administered. So whenever we are about to institute mechanical ventilation, rapid sequence intubation is our method of choice. We typically try to choose a tube which is wider, at least 8 millimeter or above for adults, so that it can help to facilitate airway suctioning, mucus plug removal, and bronchoscopy if the need arises later on. Ketamine is one of the preferred agents for induction because of its bronchodilatory effect, though it has a hyperspiratory response, which might be some of the drawbacks of using ketamine. But propofol as well is another agent that can be used with bronchodilatory effects, and it has rapid onset and deep sedating properties. However, there is the risk of using it in patients who are hemodynamically compromised, as it may precipitate the hypotension as well. So the other is succinylcholine, can be used as the paralytic or rocuronium for intubation. There's no specific recommendation which you should prefer. So deep sedation again can be achieved by using various sedative agents like propofol, long-acting benzos like lorazepam, or an opioid which doesn't have a histamine releasing factor like fentanyl, which will help to avoid the need for muscle paralysis as well. And the other thing during intubation, we need to be very careful about bugging these patients excessively because we need to avoid hyperventilating the patients, as well as we need to also keep in mind the risk of development of barotrauma. Okay, so once this treatment has been done, again, this is for the life-threatening asthma. So we need to reassess. So reassessment is very important. Reassessment can be done by seeing ideally their peak expiratory flow rate improvement. And typically for those patients who are having mild exacerbation with improvement of their peak expiratory flow rate above 70%, with sustained response after an hour of treatment, and provided they don't have any distress or physical and their physical examination has become normal, we can consider discharging them home to continue their inhalational SABA with initiation of inhalational corticosteroid as well. And we might consider a short course of oral systemic corticosteroids and patient education, reviewing their medicine use, and creating an action plan is very important. And we need to link them to their primary care provider as well for their medical follow-up. For those patients, however, who do not who have incomplete response after their initial treatment, we need to consider admission of these patients and either consider switching to IV corticosteroids and considering other adjunct therapies, as I mentioned, like especially for those patients with severe exacerbation, we might consider using ipratropium bromide as well and other agents, and we'll continue monitoring and reassessing them. If they ideally improve within the next few hours, we can observe them in an observation unit or consider hospital admission, and then we'll start the discharge planning similarly to those patients which I mentioned earlier with the mild exacerbation. And for those patients who are having life-threatening exacerbation with sustained peak expiratory flow rates less than 40%, and who are hypercarbic with a partial arterial carbon dioxide above 42 physical exam, revealing symptoms of severe drowsiness and confusion, we need to make sure they are admitted to the ICU as quickly as possible, and that we are optimizing their care using some of the strategies that we discussed earlier. So criteria for hospitalization, as I mentioned earlier, their lung function after 1 hour of adequate treatment is a more reliable predictor for their need for hospitalization than their initial status at presentation. And this is briefly what I just discussed on the table. So other some factors which might increase the likelihood that the patient might need admission: sex, age. Females have a higher likelihood of requiring admission, those who are older age, non-white race, and those patients who are taking more than 8 beta-2 agonist puffs in the last 24 hours, and if they have past history of severe exacerbations, like intubations, several admissions, as we discussed earlier, those could be some factors which make it more likely that these patients will require an admission. And the other is previous unscheduled office and emergency department visits which required oral corticosteroids, and if the patient develops these symptoms while on systemic corticosteroids, it's one factor that might be suggestive for the need for admission. So regarding the severity of the exacerbations, the severity of the exacerbation can also be one factor to determine if they need admission. If they need for resuscitation, if they need resuscitation or rapid medical intervention at arrival, if their respiratory rate is above 22 breaths per minute at arrival, if their stats are below 95, or if their peak expiratory flow is less than 50% of predicted, are also some factors. Okay, though it's not, it wasn't a part of this presentation, just to briefly tell you about asthma management cycles. The asthma management cycle, which is recommended by the GINA. So there is no standard treatment that we need to follow for every patient with asthma, well, upon initial diagnosis. So currently, it's being emphasized that there should be a personalized, catered approach to asthma management for each person. And it consists of a cycle of assessing the patient to confirm the diagnosis if necessary, the symptom control, and the presence of any modifiable risk factors, their comorbidities, the technique, inhaler technique and adherence, and as well as the patient preference and goals need to be assessed, and then we need to adjust accordingly by treating the modifiable risk factors, the comorbidities, employing those pharmacological and non-pharmacological strategies for their management, and using education and skills training and asthma management action plans to help guide the symptoms and then reviewing the response of by assessing their symptom control, the frequency of their exacerbations, the presence of any side effects from their medications, their lung functions, comorbidities, as well as their satisfaction. And based on that, for those patients who are initially diagnosed with asthma, there are two tracks which are suggested. Track one being the preferred track currently by the GINA guidelines. So for initial management, we're using preferred controller and reliever therapy, using both an inhalational corticosteroid, methanol as the reliever, and reducing the risk of exacerbations. When we compare it to using a short-acting beta agonist alone, and it's very simple because we're using a single agent, that is the inhalational corticosteroid formoterol, as both the controller therapy and the reliever therapy. So they won't need multiple medications as well, which makes their adherence better and much simpler for them to manage their own exacerbations as well as part of their action. So based on their symptoms, we will follow the stepwise approach. Step 1 and 2, we'll use an as-needed low-dose inhalational corticosteroid methanol combination. And for those patients who do not respond to that, we'll use, or for the patients who are already on step 1 or 2, who have frequent exacerbations, we'll try to step it up to step 3 with low-dose maintenance ICS formoterol. And again, if no adequate control with that, we'll go to step 4 with a medium dose of the maintenance ICS formoterol. And for step 5, we'll add other agents like long-acting muscarinic agents and possible referral to experts for phenotype testing with an additional consideration for high-dose maintenance ICS formoterol with immunoglobulin E, with or without immunoglobulin E modulators and anti-interleukins as well. This is just for the controller therapy. For the reliever as well, we will just use a low-dose inhalational corticosteroid formoterol combination whenever an exacerbation does occur while they're on this treatment. However, track 1 is the preferred agent, is the preferred means of treatment again, but whenever that's not feasible, we can use an alternative track approach, which is alternative controller and reliever. So for that, again, for the controller therapy, we are still going to use an inhalational corticosteroid whenever they take a short-acting beta agonist. And again, depending on their response or depending on their control, we might escalate based on that. But for their reliever therapy, we will use an as-needed inhalational corticosteroid SABA combination or an as-needed SABA short-acting beta agonist for the treatment. So again, the means of treatment is the track 1, where we have a single agent used both as the controller and the reliever therapy. Okay, so regarding discharge planning, prior to discharge, we need to make sure that we have follow-up appointments set within the next 2 to 7 days for our patients, or within 1 to 2 days for children with their primary care providers, or with their pulmonologists or primary physician, as I said. And the other is discussing strategies to improve asthma management, include making sure that we are prescribing the proper medications in a convenient way to administer them, and making sure that we teach them on their inhaler skills whenever we get the chance, and making sure that they have a written action plan, asthma action plan, whenever they do have an exacerbation. So make sure that the patients understand the cause of their asthma exacerbation, and make sure that you try to address whatever modifiable risk factors they may have, including maybe smoking cessation, allergen avoidance, and so on. And we need to make sure that the patients are understanding the purpose and correct use of the medications, including inhalational corticosteroid-containing controllers. So the actions the patients need to take to respond to worsening symptoms or peak flows as well needs to be discussed with them. And we need to make sure we refer them for expert advice for those patients who have been hospitalized for asthma or who repeatedly present to the acute care setting despite having a primary care provider. So no recent studies are available, but earlier studies suggest that follow-up by specialists is associated with fewer subsequent ED visits or hospitalizations and better asthma control. So we need to make sure that we are able to provide that to our patients whenever they visit our emergency department or are being discharged from our ward. So for the self-management skills and written action plan, again, as I mentioned, it's basically summarizing all the things that I just discussed. We need to make sure that we thoroughly discuss these points and cover these points prior to discharging them from ED. Okay, so thank you.
All right, thank you so much, Doctor, for the amazing presentation. So we can proceed to the question and answer. So if you have, let's answer a few questions, maybe four questions, and we can participants, if you have questions regarding the topic, please write in the chat box.
Role of aminophylline, okay. Someone asked the role of aminophylline. So again, as I said, aminophylline is currently not being recommended for use because, again, it has a higher side effect profile, but it does have a smooth muscle dilatory effect. And that was why it was previously assumed that it could help with the management of asthma. But again, it has a narrow therapeutic index and is very unsafe, so should not be used. So what is the saturation level to discharge the patient with asthma? So generally, as for adults, it should ideally be above 93. Saturation above 93 should be achieved, which is the normal goal for treatment as well, before we discharge them. Okay, I think we have another question. What is the role of aminophylline in magnesium sulfate? So again, magnesium aminophylline I already addressed. Magnesium sulfate, it has two effects. Again, one, it has the smooth muscle dilatory effect. So it will allow for bronchodilation. And the second effect is it has also a mast cell stabilizing effect. Therefore, it will reduce the release of inflammatory agents from mast cells by allowing for membrane stabilization. So what do we mean by low dose and medium dose inhalational corticosteroids? So when we say low dose and medium dose inhalational corticosteroid, we're referring to the dose, the actual dose that we are administering to them, and the frequency of the administration of that ICS inhalational corticosteroid as well. So it's a wide list based on the agent. If you'd like, I can put it in the PowerPoint as well, and I'll share it with you. But you can find it in the GINA guideline based on the specific agents. How do we treat life-threatening acute exacerbation of bronchial asthma at the ED? Yeah, so for life-threatening exacerbation, as I mentioned earlier, the first thing we need to assess ABC. If the patient is confused, drowsy, lethargic, then this patient is having a life-threatening exacerbation. You need to emergently put them on oxygen, emergently start them on a short-acting beta agonist while you are preparing to intubate the patient. Ideally, if you're in a setup which allows for intubation ventilation in your ED, you can proceed with that, and you'll continue with the agents that I mentioned earlier on the presentation. Okay, another question. Thank you for the great. Any comments on asthma management during pregnancy and labor? Okay, so during pregnancy, the only difference in management, the agents are practically the same. We'll manage it exactly the same. The only difference is our oxygen goal is slightly higher for pregnant women, especially we want it to be above 95. And some considerations in pregnancy is there is a risk that with the use of systemic corticosteroids, especially in the first trimester, the patients might develop, like the fetus might develop cleft lip and other congenital abnormalities. But again, we need to outweigh the risk of the hypoxia to the mother and the fetus as compared to the risk of not managing her with those agents. So again, it requires a thorough evaluation of your patient and case-by-case management. But again, the management is not different. We will use the same agents in the same way, for the same degree of exacerbations, and the consequences of not treating it is a lot more dangerous than like withholding the treatment due to fear of the side effects of some of these medications. Okay. How to titrate SABA based on response. Okay, so yeah, so based on response, we can consider escalating it. Typically, for a 200 microgram inhaler of albuterol, we'll try to administer 4 to 6 puffs every 20 minutes for the first hour. You can consider after the 1 hour of treatment to escalate it to up to 6 to 8 puffs per every so often. Like if it's every 1 hour that you have moved your frequent administration of the SABA, then you need to administer it at 6 to 8 puffs every 1 hour. If you're going to continue the challenge, in certain books it says that you can even continue the challenge every 20 minutes for up to 4 hours. So for up to 4 hours, you can consider increasing using the same challenge as you initially did with the 4 to 6 puffs up to 4 hours if the patient has not initially responded. How do we administer metered dose inhaler inhalational SABA for a ventilated patient? Okay, so that's an excellent question. For metered dose inhaler inhalation for SABA, ideally you need to use a nebulized acting beta agonist albuterol, like the 2.5 milligram per 5 ml vials, which are commonly available. Ideally, you can try to use those, but as we are in a resource-restrained country and certain centers might not have that available, what you can do for that is you can try to have an adapter port added to the mechanical ventilator circuit, and that is the adapter port should be added to the inspiratory port, and we'll try to synchronize the administration of the metered dose inhaler through that adapter with the inspiratory breath. Or we can try a manual inspiratory breath on the mechanical ventilator as we are administering the medication. Okay, another question is for how long patients should take steroid upon discharge. So steroid should be taken no longer than 7 days. Ideally, a short course 5 days is sufficient, and there's no advantage in even the longer course as compared to a shorter course of the steroids. So Daniel Dani asked, what triggers asthma? So again, there are a lot of precipitants, if that's what you mean. Like for precipitants, it could be anything. It could be environmental, it could be exercise, it could be medications like aspirin, NSAIDs. It could be due to pollen, it could be due to dust mites, it could be any wide range of factors could trigger asthma. Okay, mild asthma and steroid use. So again, we don't use systemic corticosteroids for mild exacerbation of asthma. That's the only condition in which we're not required to use asthma. We're not required to use an oral corticosteroid. Rather, for those patients, you can consider initiation of the inhalational corticosteroid with the long-acting beta agonists like formoterol, which will have a fast onset of action and can also help to treat your acute exacerbation. Okay. What is the place of ketamine in the management of life-threatening asthma? Okay, so emergency medicine textbooks suggest using ketamine initially for its bronchodilatory potential. So it can be used at 0.5 to 1 milligrams per kg IV stat. And then you'll use a 1 milligram per minute continuous infusion, which is considered subdissociative, and you'll try to use that to help with the bronchodilation. But again, it is predominantly based on evidence from certain case reports and is not up. There is no like RCT or multicentric trial which tried to identify whether ketamine should be a standard staple in the management of life-threatening asthma. But for a patient with life-threatening asthma, you need to keep in mind that this patient highly likely requires intubation, mechanical ventilation, and once that has been in place, you can consider using ketamine as the sedative, because you will take also advantage of the bronchodilatory effect of the drug. But again, as I mentioned earlier, it does have the side effect that it will increase secretions. So there might be a slight risk that there will be a higher degree of mucus impaction and difficulty in airway clearance. Okay, how frequently can we give oral corticosteroids before having to refer to senior specialists to outpatient setting? Okay, so that's a good question. So oral corticosteroids, prolonged use is not recommended in the sense that, for example, if the patient is having a frequent exacerbation every month to the point where they're requiring short courses of oral corticosteroids, the lifetime accumulated risk of using these systemic steroids puts the patient at a higher risk for developing other complications like osteoporosis, like diabetes, heart failure, and other comorbidities as well. So it's not recommended. If the patient is having frequent exacerbations that are necessitating oral corticosteroids, you need to address whether this patient is actually properly, first off, whether they are on an inhalational corticosteroid. The second thing is whether they are appropriately taking their inhalational corticosteroid. And the third thing is whether if the asthma is like due to some specific phenotype, which might benefit from the use of other agents like long-acting muscarinic agents, the interleukins, the leukotriene receptor antagonists, and so on. So there is a point that I have come across, but what I suggest to you is that whenever you are facing a patient who requires frequent systemic corticosteroid, you need to make sure that they're referred as soon as possible. So ideally, if they're having more than 2 or 3 exacerbations, you should probably refer them. Okay, can we give magnesium sulfate concomitantly if patient have severe asthma, or do we wait and see if she responds to SABA and IV steroids? So again, magnesium sulfate is reserved for those patients who are not responding to initial treatment. So ideally, what you have to do is just give the SABA. And depending on the severity, you might give oral or IV steroid. If the patient is not responding to this after an hour reassessment, you can consider administering the magnesium. Okay. Can oral steroids used for controlling mild asthma for longer time? No. They should not be used for a longer time. How long can we use long-acting inhalational corticosteroids in pediatrics, and do we have pediatric preparation in our country, since the ones we use are for adults and dose adjusted? Yeah, so that's a good question. So regarding for how long we should be using inhalational corticosteroids, so it depends on the patient's symptoms. So even for pediatric patients, currently there's the MART strategy, which is using it both as the controller as well as the reliever therapy. So inhalational corticosteroids will be required for the patient throughout the course, throughout their, well, I'm not an expert in this area, but I think throughout their life, as long as the symptoms persist. The only thing is maybe the dosing, the frequency might be different. And regarding the preparation, pediatric preparations, I'm actually not aware if there are pediatric preparations currently available. I think if one of our colleagues maybe in pediatrics is available here, they can comment. how many doses of magnesium sulfate can be given? Okay, so that's a good question as well. So in the standard texts, what it says is that you can administer a single magnesium sulfate bolus after the 1 hour trial. For life-threatening asthma, you'll use it initially as well, concomitantly with the SABA and the steroid. But sorry about that. Okay, but you can try a second dose if there is no response in a few hours, provided that the patient doesn't have any other concomitant comorbidities, like renal insufficiency, where magnesium sulfate administration might precipitate toxicity because of decreased clearance excretion. So, provided there is no contraindications, provided that you are following the clinical parameters for magnesium toxicity, and as long as you can possibly have frequent measurements of the magnesium levels, you can try repeated boluses, but I haven't come across any maximum dose that you can give for that type of condition. Okay. All right. Thank you.
All right. Thank you so much, doctor, for the amazing presentation and taking your time to answer so many questions. And I believe it was a really informative presentation. Thank you so much, and we won't be holding you any longer. Okay. If you have any last remarks, maybe regarding the topic, you can add that and conclude.
Yeah, okay. So again, thank you to Blue Health for this forum. It's very useful for physicians to always try to stay up to date on various topics, and you guys are one of the catalysts for us to achieve that. So I want to thank you guys for all you do. And regarding the topic, again, this is a very wide topic with various recommendations. So it's good if we have like a multidisciplinary type like a conversation or like presentation about this from various angles. And regarding the long-term management, outpatient management of asthma as well, it would be nice if we have our colleagues in pulmonology critical care to try and chime in and help us to deliver the better care for our patients. So again, thank you guys. Thank you all the participants for staying attuned to this presentation. So thank you.
All right, thank you so much, and we'll try our best to bring some of pulmonologists here with us again. And on behalf of Blue Health and our community and our attendees, we'd like to thank you and wish you a good night.